this video, we'll be talking about asthma. Asthma is one of the major non-communicable diseases in the world. The World Health Organization says that there are over 235 million people suffering from asthma. And this ranges from very mild asthma to quite severe asthma. So it's no surprise then that we see on insurance applications and claims assessments the word asthma. And often, insurance employees often get anxious about seeing that word. But there's no need to fear, because if you know the basic pathology of asthma, how health professionals view the severity of asthma, and what are the pitfalls we should look out in insurance medicine, then the assessment of asthma should go fairly easy. In our previous video, we spoke about the journey of an oxygen molecule. And if you can recall, we spoke about the entire airway, the upper respiratory airway and the lower respiratory airway. And when we hit bronchi, we spoke about 20 branches of the bronchi. And in asthma, in the bronchi, that's where the pathology sits. What is asthma? Asthma is a disease of diffuse airway inflammation that is brought about a trigger. And this trigger is started in your body by some stimuli you're reacting to. But the most important concept of asthma is that it is reversible airway constriction, which means that there are times when an asthmatic is perfectly normal, and you can't tell this person is an asthmatic compared to the normal population. And only when those stimuli come into play, that's when you have this bronchoconstriction. To express it in another way, let's take a look at a cross-section of the smallest functional part of the lung. What is that? That's the alveoli. And as you know, the bronchiole ends in the alveolus. If I should cut through that, I get a cross-section. In the normal bronchiole, we'll see the smooth muscle that surrounds this airway. In an asthmatic, the smooth muscle contracts, and it makes that airway far smaller. So there's less oxygen coming through that constricted airway. But not only that, besides the airway or the lumen being far smaller, you also have lots of mucus production. So you can well imagine that oxygen molecule now competing with other oxygen molecules to come through this congested, narrow airway, a lot like the freeways when we're trying to come to work in the morning. It is problematic, and the alveoli is getting far less oxygen and other air to exchange for the carbon dioxide it needs to expel. So how do we recognize an asthma attack? As I've told you, the oxygen molecules are now far less for gaseous exchange. And because of that, you're going to feel short of breath. And you're going to feel as if you must breathe faster to get more oxygen to exchange in these constricted airways. Coupled with this, the lungs are trying to expand. And because they're trying to expand to get more oxygen in, you're going to feel tight across your chest as the lungs is trying to do this. In addition to this, if a doctor listened to your chest during an asthma attack, we're going to hear wheezing. What is wheezing? It's air trying to rush through a constricted or narrowed lumen. The airway is far smaller now, and that same air that we hear with the normal breath sounds, which sounds, we no longer hear. It's as if wind is trying to whistle through cracks or little openings that are very narrow. And that's what wheezing is all about. It may include a persistent cough. Remember, I told you it wasn't just bronchoconstriction, but you also have lots of mucus production. And this mucus causes irritation to all those bronchi, and it feels as if you need to expel it. So how does a doctor diagnose asthma? Well, the doctor will take a clinical history, irrespective of whether he is one of those 5 to 10 minute doctors or even a 20 to 30 minute doctor. He's going to listen to your story. And your story is classically going to include something like, I don't understand this, doctor. My chest is feeling really tight. And just when I was about to go to you yesterday, all of a sudden I felt better again. But now I'm feeling again tight. So there's a history of feeling really tight or short of breath. Coupled with a history, there are times when the person feels completely normal. When the doctor examines you and you are still feeling tight when you've come to the doctor, he's going to hear wheezing sounds. He may also hear the sounds of mucus trying to come through, and that's when we hear what we call crackles or rhonchi. Or the doctor may hear nothing, because if you've come to the doctor, you no longer have that stimulus that's triggering your asthma, you may be perfectly normal. It will also be confirmed on special investigations the doctor can do in his side room. With a spirometer, we can do lung function tests, and we can see that there'll be a fall off in how much breath you can expel out once you've taken a breath in. Or just a peak flow meter, which is a very easy thing to see. We compare it to the normal population to see whether you are blowing as much out as the normal population based on gender, age, and height. So this is almost common sense. It's almost listening to what Granny says. The treatment of asthma has to trigger on two things. The first thing is try and remove the stimulus, because if you can remove the stimulus that causes your asthma, there won't be a need to treat asthma. So if you are allergic to curry, it makes sense then to remove curry from your diet. You'll be surprised how many people know what triggers the asthma and they absolutely refuse to do anything about it. However, there are some things that makes it far difficult to remove the stimuli. For instance, if your stimulus is actually exercise, we're not going to tell you do not exercise. We are going to tell you use some preventative medication before you exercise so that you can get your full training spectrum in without having to stop because you're feeling short of breath. And that's what we mean about trying to reduce or remove the triggers. The next part of the treatment is drug therapy. Some of us are just allergic to everything around us. House dust, cotton, wool, anything that's on our bodies. So then we have to treat the asthma. And this involves two things: trying to prevent significant asthma attacks and also trying to treat you while you have an asthma attack. Now, the best forms of medication for asthma are those that we can inhale. Why? Because it acts directly on the airways. It's a fast turnaround time to see whether or not you're improving. And also there's no systemic side effects because it's only acting on the airways. Amongst that basket of treatments, we call the first line of treatment beta agonists. And they are there solely to open up the airways so that bronchoconstriction is removed, even though you still have a stimulus in the air. And then we'll move on to the preventative medications. This can be inhaled or taken orally depending on the severity. And they will often include some form of corticosteroids, as well as other medication that tries and prevents airway obstruction. If it is very severe, then you're going to need oxygen nebulizations, often an admission to hospital, and many hospitals have in fact in the casualty a corner that they call the asthma corner for those asthmatics who need just for 18 to 24 hours oxygenated nebulization and intravenous medication. The intravenous medication is only there so that the steroids can work faster, but it's the same ingredient you take when you're taking oral steroids. So the important thing about asthma is that it is a completely treatable disease. Can we ever get rid of asthma? Yes, if in an ideal world you can remove the stimulus for your asthma. But it is a preventable disease, and for the most part, you will not recognize an asthmatic from the normal population if they are compliant on medication. So what are the pitfalls or the worrying factors in insurance medicine? What are the things we have to look out for when we're underwriting the case? Well, the frequency of attacks. Now, there's a huge disclaimer before I even start with the frequency of attacks. It does not matter if the 33-year-old was a bad asthmatic when he was 6. It matters the last 3 to 5 years. So asking detailed information about how many times you were hospitalized as a child for asthma and now you in your 30s makes no sense whatsoever. But we do look at frequency of attacks. What do we mean by that? If somebody was only having 1 or 2 attacks 5 years ago and now started increasing the attacks, we would be concerned whether this asthmatic is getting more severe. In addition, if we note that there was hospitalizations included in these attacks, that would be a cause for concern. The other thing that will tell us that this person perhaps is becoming more uncontrolled is the medication history. If somebody only started with an inhaler now and then, a Ventolin inhaler, usually you hear the history, or Beditech inhaler, but over the last year they've added a steroid inhaler as well as oral steroids, you should ask yourself, why do they need those medications now when they did not need it in the past? And that would prompt you to ask more medical information. Hospitalizations. I alluded to this with the frequency of attacks, but it matters over the last 2 to 3 years, how often the person was hospitalized for asthma. In addition, we'll look at serial lung function tests. Now remember, when an asthmatic is having an attack, the lung function test is going to be poor because there's bronchoconstriction, we know that. But if we look at serial checkups by their respiratory physician or their GP, and it is year on year getting worse, that would be a cause for concern. The other thing we have to closely look at is when somebody asks for disability benefits. And this is where the most claims for asthma comes from. If somebody works in a dust-filled environment, and one of the stimulus is dust, then it stands to reason that at some point, if the asthma becomes uncontrolled, a doctor is going to say they can no longer work in that environment. So it matters what occupation you do. We've had many successful claims with regards to people who work in a baking environment and now they're allergic to the wheat and the flour. We've had successful claims with people working with animals and they're allergic to dog hair. And so it does matter when you even hear that they're alluding to only 20% of my job is working with the animals, most of it is in the office. Even asthmatic, you need to ask then, what are your stimuli or your triggers for your asthma? So the occupation matters in an asthmatic, and whether or not that occupation includes some trigger or stimulus that may trigger your asthma. Coupled to this is the risk product asked for. I spoke now about disability benefits, but temporary income also makes a difference with asthmatics. If we've heard that the frequency of attacks is more, and even though the occupation has no trigger or stimulus for the asthma, but we know that they've been 7 times off last year because of asthma, then it stands to reason that temporary income might be a risky thing to offer somebody who is now having poor control of the asthma. So the risk products they're asking for also matters. I can vouch, I've been in the insurance industry for more than 10 years, that most asthmatics get for all products ordinary rates. It is only on a rare occasion that severe asthmatics will get a risk rating, and it's usually on the disability products and the temporary income products. As I've said at the start of this video, that there are 235 million people with asthma. And for the most part, when the asthma is well controlled, they're unrecognizable from the normal population. Well, I hope this video with regards to asthma has been helpful, and that you've been able to work out what's the basic pathology and what are the points that matter in insurance medicine.